very much for the kind introduction. And thank you to our amazing collaborator, Dr. Sido, for introducing the concept of biotin-related mitochondria selective peptides. And I'll be talking about using this peptide in a major clinical problem, which are diabetic wounds. So as a declaration, Dr. Sido invented the SPN15 peptide, and our project was partially funded by SPN, Social Profit Network, who also owns the patents for SPN15. So diabetic wounds, such as chronic foot ulcers, affect up to 34% of patients, and these patients are in increased risk of infection, prolonged hospitalization, and in severe cases, amputation. These wounds form in areas of increased pressure, such as the foot, where the impaired circulation creates very hostile wound environment. They significantly increase the healthcare costs and decrease the quality of life of patients, but despite this, the treatment options are quite limited. For any effective healing, we need energy and we need substrate, it's biosynthetic input. What happens in diabetic wounds? The fibroblast contractility is reduced, the fibroblasts cannot migrate effectively, and the matrix production is reduced. All these together significantly reduce the tissue healing. So Dr. Sido already introduced us quite in detail to SPN peptides, and I'll be talking about SPN15. So I'll just quickly go over its unique dual function, the cardiolipin targeting sequence, and vitamin B7 known as biotin. So biotin acts as an important cofactor in healing processes, where inside the cell it supports the acetylcholine A carboxylase and enables fatty acid synthesis, which is important for membrane maintenance. In mitochondria, the carboxylase is supported by biotin then replenish the TCA cycle intermediates, which are then diverted to anabolic processes. The cardiolipin targeting region promotes inner mitochondrial membrane curvature. It facilitates electron transfer, and together these functions address both energy and anabolic demands of healing. So we wanted to test the SPN15 peptide in tissues that are marked by mitochondrial dysfunction and substrate depletion. So we chose diabetic wounds as a model for these clinical entities. We wanted to test if SPN15 would improve diabetic wound healing, and we used 2 diabetic mouse models for this. Our hypothesis was that SPN15 would accelerate wound healing. We used 3 groups of mice. We had normal B6 mice as a control. We had moderately obese mice with diet-induced obesity, and genetically insulin-resistant mice with a spontaneous leptin receptor mutation, which serves as a severe obesity model. We created 2 6mm large wounds in 20 weeks old mice, and we treated these wounds with either vehicle, which was hydroxyethyl cellulose, or with 1 millimole per liter SPN15. During the first 6 days, we treated daily, and then we reduced to once daily from day 7 to 14. We took daily photographs, we recorded health outcomes and weight, and we had 2 sample harvest time points, day 7 and day 14. The number of mice per genotype, treatment, and time point group was 3. We calculated wound closure in image J using the daily photographs. We used a published rubric to score the health assessment, and we also scored inflammation and tissue repair profiles in histologies stained with H&E and trichome stain. Using transmission electron microscopy, we quantified mitochondrial morphology, and we looked at outcomes such as mitochondrial size and shape, crystal density and thickness, and membrane thickness. So SPN15 accelerated wound closure in all wound models, where in moderate obesity we observed an interesting contrast, where in the vehicle control treated group, the wounds actually increased in size during the first 12 to 24 hours, while in the SPN15 treated mice, the wounds contracted. This could potentially be explained by improved myofibroblast contractility, where they need a lot of energy production and are highly dependent on the available energy. The leptin mutant mice had larger wounds overall. This could be explained by higher mechanical tension in the skin, but despite this, we still observed marked effect of SPN15. Looking at inflammatory profile, we saw an interesting difference in the function of SPN15 in the different models of mice that we used. In normal B6 mice, the neutrophilic response was actually improved or enhanced in SPN15 treated mice, where likely the increased debridement and increased immune signaling had a beneficial effect in healing. While in the diabetic models where chronic inflammation is already a problem, SPN15 actually decreased inflammation. When it comes to repair, we saw better scores in fibroblast alignment and epithelialization at 7 days, and better dermal structure in the scars at 14 days. Looking at our TEM images in image analysis, we saw larger mitochondria in the treated severely diabetic wounds at 7 and 14 days. And while this can sometimes mean dysfunction, having larger mitochondria isn't always great. We also saw that at 14 days, the SPN15 treated mice had greater Christie area. And looking at mitochondrial shape by minor and major axis, they had more elongated mitochondria in the treated group compared to the vehicle group, which had more rounded mitochondria. So all this together, these preliminary data, which we're still analyzing, it can suggest that SPN15 could potentially act as a rescue drug to promote mitochondrial fusion. So these are important findings. SPN15 accelerated wound closure in all our genotypes, significantly improved repair quality, and reduced or modulated inflammatory score, and our preliminary data show good potential to improve also mitochondrial ultrastructure. And this is the first sort of result that we're presenting on SPN15 acting as a potential mitoprotective and anabolic therapeutics in tissues that have mitochondrial dysfunction and substrate depletion. I would like to thank our amazing collaborators and my PI, Dr. Delco, who's the head of Delco Lab, Dr. Cito for supporting this project, our students, and Social Profit Network for keeping supporting us. And if you want to learn more, visit our poster. Thank you.
So, any questions?
What do we know about mitochondria in senescent cells? And what do we know about stimulated agents, which have become very popular? There are things like Zucker, as well as other normal constituents of the diet that are involved in flavonoids that are involved in reversing senescence. Does anybody know anything about what those molecules do to mitochondria? They clearly can kill senescent cells, or they can reduce the senescent phenotype. I think well established. So is there anything known about mitochondria in that situation?
We have currently mechanistic studies ongoing, so we might have some results which might answer some of your questions later, but I'm happy if somebody else...
I think somebody else has an answer here.
In our field, our lab's first field is cartilage and osteoarthritis, and it's very common in the last handful of years to see senolytics, and there's a lot of research going on. They actually kill cells undergoing senescence and cells with the senescence phenotype. Our hope is to rescue those cells rather than killing them off, especially in hypocellular tissues like cartilage.
But senescent cells, when they hang around, are bad. They produce all kinds of pro-inflammatory things, and we accumulate them. And there have been a lot of experiments trying to get rid of them. And human disease like chronic pulmonary fibrosis and kidney disease.
Right. And so rather than kill off the cells that are expressing the SAS phenotype, we would prefer to reverse that phenotype rather than kill the cells, especially in cells where we can't repopulate the cell loss once they've been gone, and we have preliminary data that supports these peptides and that.
I think my voice is deep. All senescence, I don't think can be qualified as bad because wound healing is a form of beneficial senescence, is it not? So, there is I'm horrible remembering PI names, but a professor showed that mitochondrial dysfunction was integral to generation of senescent fibroblasts, and that contributes to SASP as well. So that's as much as I remember.
So, can we...
To add to this discussion, because our lab works on senescence a little bit as well in retinal pigment epithelial cells, which are non-dividing. So, like you said, we don't want to kill them. There are different stages of senescence, and the mitochondria seem to be different at those different stages, both early and late. So I think you bring up a really interesting, but also really complicated question that deserves more work, but I don't think we can answer it today, in my opinion. Somebody can, I'd love to hear it, but it's complicated.